Okay, we're live now.
Okay, cool.
Hi everyone, welcome back to another virtual shadowing session with Predental Universe. I'm Tiffany and I'll be helping facilitate this session today. We have an exciting presentation today with Dr. Eli. And on that note, feel free to take it away whenever you're ready, Dr. Eli.
Okay, great. So let me introduce myself, I guess. So I'm an oral surgeon. I went to dental school at UCLA and I graduated in 2014. And then I did oral surgery residency in Oakland, which was part of UOP, like University of Pacific, and now it's part of UCSF, I think. And I finished that in 2018. So I've been in private practice ever since. So basically, I was kind of making this a lecture that would go over what oral surgery is and what are the things you need to do if you wanted to pursue it during dental school. There's some people who go to dental school wanting to do it. There's some people who kind of find that they like it during dental school. I was kind of in the middle of those two. It is a good idea to know what oral surgery is. It's very different from what you do in private practice. Like if you go to an oral surgery office, like a local one, you're mostly going to see them doing like implants and wisdom teeth, kind of. But the things you learn and the things you can do if you choose to go to like that subspecialty is removing like jaw tumors. You can do jaw fractures, jaw repositioning surgeries, and jaw reconstruction. So I'll go over kind of like those individually. Implants, like I was saying earlier, kind of when they first started, they were mostly done by oral surgeons, but now general dentists are doing them, periodontists are doing them. So you don't really need to go to an oral surgery residency to do implants. You can do that. I mean, some dental schools have you place implants before you graduate now, so it's not really exclusive to oral surgery anymore. But like this is like in the 90s and early 2000s, it definitely was. But anyway, so how to apply? The first things you need to do, obviously, is get into dental school, and then once you're in dental school, your dental school will make you do rotations in each subspecialty before you graduate. So they'll have you do a couple weeks of like pediatric dentistry. They'll have you do a couple weeks of orthodontics or a couple weeks of perio, depending on what your school's program was. And then you'll do a couple weeks of oral surgery also. So once you do that, then if you like oral surgery after that, what you need to do is called Externships, which is basically you leave your dental school and you go to an oral surgery program where people are actually learning like that they're in residency, and you spend a week with them, sometimes 2 weeks. So I was at UCLA. I did my externships in New York and at Montefiore Hospital. I did my own program in Oakland, and I did another one in Washington, D.C. So each one was a week. It does kind of put you behind for your requirements for dental school if you need to get a number of procedures done. But it's a good way to get your foot in the door, so when interviews come around, you have like a relationship with the program you want to go to. And then in your third year of dental school, you have to take an NB&Me exam, which is basically a test on the basic sciences of healthcare, like how to treat a lot of diseases, and you learn that in your first 2 years of dental school. So once you take that exam and you've done externships, your application is essentially complete, and then you apply in your fourth year. It's not called oral surgery school, right? It's called residency. It's another 4 to 6 years of school after dental school. And if you do a 6-year oral surgery program, it's basically 4 years of residency where you're doing surgery, and then they make you do 2 years where you go to med school, so you get an MD. So if you see someone who's, their initial DDS MD, they did a 6-year program. If you're like me, you're an oral surgeon that went to a 4-year program, the MD is not there. So there's pros and cons. the people who did 6-year programs will tell you to 6-year programs. The people who did 4-year programs will tell you to 4 years. There's always kind of a bias, but just see what you want to do or what you desire. I didn't want to do an extra 2 years of school because I was like, this is 8 years after college. It's enough. So I don't want to tack on the additional 2, but a lot of my friends did. So if you want to be more hospital-based and do those kind of bigger surgeries I was talking about, and then I'll show you, probably better to get an MD. But if you don't, it's not the end of the world. And residency is very different than dental school. Okay, so dental school is kind of more like college. You're going to have like classes and exams, classes and exams, classes and exams. Okay. Residency is going to be wake up in the morning, you got to do a surgery you've never done, study it, how to do it, and it'll be, you know, your professor will do one side of the jaw and you do the other side. So they're kind of watching over you. So like for me, half of my professors were left-handed coincidentally, so I'd stand on the right side. And then when my professors were right-handed, I would stand on the left side and we do it together and I just watch over you. So it's a lot more involved. You don't really have classes, okay? It's kind of more on the go, on the go, on the go. So a lot more high energy, a lot less sleep. And you know, when you guys start dental school, you'll see that you kind of like lose touch with like your friends in college because you're kind of alienated. But with residency, it's like that times like 10. So it's like a big challenging sacrifice, but it's fun. And then this is kind of what my schedule was like. My first year, you did 4 months oral surgery, 6 months of anesthesia. So you learn how to put people to sleep. And then you do 2 months of medicine with like MDs. So you're just like treating everything like diabetes, high blood pressure, and all that stuff. Your second year, you do general surgery. So you do like cancer surgeries. You do like colon ruptures, surgeries on the lungs, like everything like a general surgery doctor does. And then back to oral surgery. And then our third year, we did plastic surgery, maybe pediatrics, then oral surgery. Last year, it's only oral surgery. Am I talking too fast? Are you guys picture everything good? Yeah. All right. Any questions about any of that so far? No. Okay. So motivate. So yeah, once you guys posted that I was doing the lecture, a lot of people asked me what pushed me to do it. So I kind of, like I said, I was kind of 50-50 on doing it when I went to dental school. I said I was either going to be a dentist or an oral surgeon. And then the real thing was seeing the surgeries in dental school. So when you're in dental school, you should really just try to see every specialty as much as you can. Like really just go there and watch them do it. And whether it's perio or whether it's like orthodontics or pediatrics, whatever, you should just really kind of just go to that clinic, go to that floor or wherever it is in the dental school, and kind of like see if you actually like it, because you're gonna be married to it essentially. So I really liked oral surgery, and so kind of reinforced my idea that I wanted to do it. Yeah. So that's kind of the best advice that I have. If you don't know which specialty you want to do, or if you don't even know if you want to do it, just go to those specialty clinics and just watch the residents and everyone do what they're doing and see if you like it. Okay, so let's see what it is. So this person had an underbite, okay? So like their lower jaw was further out than their upper jaw, okay? So we were gonna push her lower jaw forward. Okay, so I'm just gonna, I don't know if you guys can do blood or not, but this is kind of, we've attached upper jaw.
Oh, that's disgusting.
Oh, this does, that's kind of, and then you secure it back on using metal plates. Okay, and then, so I'll show you this. So this is orthodontic surgery. This is, you work with someone who does braces. So the patient wears braces for 6 months. And then at the 6-month mark, you do the surgery and position it where you need to go. And it really depends on whether the upper jaw is too small or whether the lower jaw is too big. Or sometimes it's both, and you have to do both. Because if you push the lower jaw too far back, it gives people a double chin. And when you bring the upper jaw forward, if you bring it forward too much, you kind of give them like buck teeth when they're done with smiles. So you got to kind of calculate it. I'll show you how that stuff works. Okay, and then this is a surgery that I did. So this is not orthognathic, this is pathology. So this is a tumor, okay? You can see here, his face is a little bit fuller over here. And so he came into the office saying, the right side of my jaw is bigger and it's been painful. So what we did is called an FNA, okay? That's when we put a needle into something that's swollen and take a sample of it out and give it to the lab. And so the lab came back and said it was polymorphic adenoma, which is basically a tumor of your salivary glands. Okay, so the biggest salivary gland that makes your saliva is below the lower jaw. So that's kind of what his swelling is there. Okay, and so it has to be removed. Okay, it's not cancerous, but they can get pretty big and they can eat away a lot of healthy tissue, but it's not really. It's a benign tumor. Okay, so here's some more pictures of him. You can kind of tell it's a little more puffy here compared to the other side. Again, a little fuller here. You kind of see all of it. Is my mouse showing up or?
Yes.
Yeah, okay. So here. And we drew it out here. So this is about like 6 centimeters, okay, or like 3 inches. So inside his mouth, there's no real, you can't really see anything intraorally. It's always good to get a picture inside someone's mouth whenever you're doing the surgery. You can notice he has staining and he has a crossbite on the side, but it's kind of irrelevant to the surgery itself. So the submandibular glands, you kind of see these, if you ever look at your own tongue, you kind of see these holes on the side. This is where the saliva comes out from the submandibular gland. Okay, so you can see here it's open. Sometimes it gets clogged, some people get stones. This is X-ray. There's nothing on the X-ray. So when someone has a tumor, dental X-rays don't really apply. You have to get a CT scan. So this is a CT scan. It's kind of hard to tell what this is when you don't look at them all day. I remember when I first looked at CT scans, I didn't know what I was looking at, but this is called axial cut, so it's going down the person's face. Okay, so going from the hair, from the hair down to the jaw. So right now we're in the middle of the jaw. So these are his lower teeth here. This is TMJ joint here. And so we're gonna go lower past the jaw so we can kind of see the tumor forming, okay? So this is it here. These are like your jugular veins. Okay, so you can see how big this thing is here. Now we're going sideways through his face. You can kind of see how big this thing is here again. And now this is the front of his face going towards the back. Okay, so these are the measurements. Okay, so it's about 6 centimeters. I have 3. And so we had him agree to go into surgery. These are the pictures, okay? So we drew out his jawline. And to remove this, you have to go below the jaw, okay? Anytime you go below the jaw, and you're gonna make a scar on someone's face, you see the neck creases here? You wanna make the scar look like it's gonna be a neck crease, so it looks natural. You don't want it to be parallel to the jawline, because it won't look natural. So when this scar is here, it'll kind of scar and look kind of like his necklines. So that's kind of the idea behind doing it this way. So now we went to the skin and first layer of fat, okay. This is the muscle, this kind of red, kind of see these red stripes. This is muscle, okay. These like yellow goblets or fat tissue, you have to go under the fat. So now we're through the muscle. We just went through here. We made an incision along the dotted lines. It's kind of hard to see, I guess, on this computer, but this line here, if you can kind of see that, this is the facial nerve. This is the nerve that moves your lips. Okay, so it goes below the jaw and comes back up. So you don't want to tear this nerve when you're doing the surgery. So this sends a little shock of electric currents. So if it hits the nerve, it'll make the patient's jaw move, and then you can properly identify it and avoid touching it again during the surgery, because the tumor is deep to this nerve. So, we identified it, pushing it to the side. And now we kind of start seeing the tumor more. Now we really start seeing it here. Okay. Now we're just kind of scooping it out. This is me kind of holding it here. Tying it off. And it's removed. There's kind of a big defect here where the tumor was. Then you close in layers, and then this is kind of the scar line we were talking about. So this is it. It's a big old thing. It's basically essentially a little bit bigger than the size that we found on the X-ray, but we took some additional tissue with it. Because with this tumor, or with any tumors that can spread, you need to take like the tumor itself, you have to take some tissue around it, because the tumor can seed into other tissues. So you have to be a little bit more liberal and take more than what you see. Because there's always a chance that under like a microscope, you can see some tumor cells in here. And if you do an incomplete removal, it'll grow back. Okay? So we took some healthy tissue also. And just split it down the middle for fun. This is what it looks like in the middle. And you send it to the lab looks under a microscope, and findings the submandibular gland resection correlate with patient's previous right submandibular gland FNA, is polymorphic adenoma. So we want to rule out carcinoma. Okay, so it's kind of good to know the names of dangerous tumors versus non-dangerous ones. Anything that's a carcinoma or sarcoma is cancer. Anything that's like an oma that doesn't have a sarcoma or carcinoma in it is benign. That's kind of the truth. Okay, so that was that. Any questions about that one before I show something else? No? Okay, cool. So
actually, we have one question, sorry. It says, how do you make sure nothing grows in the pocket where the tumor used to be?
Okay, yeah. So what you do is, so this is a case you're going to keep in the hospital, okay? And you're going to do dressing changes, and you're going to you wrap something very tight along the patient's face to put pressure on it, okay? Because this whole area, it's called like a negative space or dead space, is going to grow with like a blood bruise. So you have to keep a lot of pressure on it so nothing grows. And you're going to keep him in the hospital. You're going to look inside of its mouth, and you want to make sure the floor of the mouth is not elevated, and that is able to move his tongue, and you're going to check the incision itself. So it's kind of like wound management that you do in the hospital. Yeah. And that's the short-term stuff. Long-term, you're going to keep the patient on a follow-up, where you're going to keep them coming back to your office every 3 to 6 months, and just evaluating to make sure there's no growth and everything. Yeah.
Thank you so much.
Okay. So this guy was an employee at the hospital we were working at. He got into a fight, and his front teeth got knocked out. Healthy guy. I'm assuming a lot of guys showed you implants already through like other specialties, so I'm not going to go like spend too much time on it. But so anytime you have an implant patient, what you need to look at is what the patient shows at rest. Okay, so are they showing any gum tissue? Are they only showing tooth? How much tooth are they showing? And compare that to their smile line. So when a patient's doing their biggest smile, are they showing any gum tissue, or is it only white? And if it's only white, what percentage of the tooth are they showing? Are they showing the whole thing? Are they showing parts of it? You need to work with the dentist to understand like what kind of crown you're going to make at the end. So we made him a partial, like a flipper. So you can see that it's replacing those 2 knocked out teeth. He knocked out his front tooth and the tooth just to the side of it. So this is what he looked like after the fight. You can obviously see the 2 sockets where the teeth were. And these are clots. This is what fills in an area when a tooth is extracted. Okay? And then eventually, this is going to turn into gum tissue. This is flipper in there. So this is the X-ray, okay? So it's called like a radiographic splint. So we put a composite or something else that'll show up on an X-ray in the ideal size of what we want the crowns to look like. And then we have the patient take an X-ray with that on. So this shows up in the X-ray, and you can see where you want the implants to go. So this is where one of the sockets are. This is the radiographic splint here. And you can see this is where the tooth was. So that's going to be the other tooth. So the other tooth, part of it is still in the socket. It, got chipped, but it got chipped, but part of the root tip was still there. So we knew we had to remove that during the surgery. Okay. And this is a PA X-ray. How familiar are you guys with X-rays? Does any of this make sense, or is it like too abstract? Yeah, good.
To a certain extent, like I know. Well, for me specifically, I know like the basics, like PAs, periapical, and then like how to look at the different X-rays on the graph.
Okay, cool. Is that like the same for everyone, or I'm sure it's all over the place.
I don't think so.
I'm pretty familiar with X-rays. I have like a dental assistant experience.
Okay, cool. All right.
I think it would be good if you just say what these terms mean, just so if everyone doesn't know. They can,
Okay.
Yeah, thank you.
Okay. So, okay, let's go over this X-ray. Okay, so this is a socket. This is the area where a tooth was. So this patient's tooth is still here, right? This is the root that anchors the tooth into the jaw. When a tooth is removed, you're going to see a socket. It's just the tracing of the original tooth. Now the neighboring tooth also got knocked out, but you can kind of see inside the socket is this. There's an incomplete removal. This is still part of the tooth here. We have to remove that. So dental implants are tooth replacements. They're made out of titanium. So they're gonna look like these screws here. And titanium is the only metal that you can put in a patient or a person, and the body doesn't have like a foreign body reaction to it. So if you ever notice when you get a splinter and like in your skin and that area swells, with titanium that doesn't happen. For some reason, our bodies recognize titanium as our own body, so this is why they're used for implants. And you will grow bone around them, and once the bone is grown around these implants, it'll function like a normal tooth. So first part is putting in the screws, like the implants themselves, and the second part, 3 months later, we'll be putting in the crown restoration. So this is kind of looking at our X-ray. This is the ideal placement of where we want the implants to go when we're planning before we do the surgery. So these are our measurements of how wide and high these two sockets are. These are the areas where the teeth were. And then implants come in various sizes. They have a width and a height. So you have to plan what size implant you're going to use for each implant you place. It's not one size fits all. They're different sizes. And based on what you need to do or what the X-ray is showing you, you have to determine what size implant you want to do. So for tooth number 7, which is the lateral, this one, that's like your tooth on the side. It's smaller than your center tooth, your central incisor. So we went with a little bit of a narrower implant, 3.5, whereas central tooth, which is wider, we did a 4.3. This is the actual implant placement. So here's our socket. And when you place an implant, you're doing drills of various sizes. This is the first drill. This is our second one, our third one. And then now we've placed the implant into the socket. Okay. Now we're gonna do the same thing for the second tooth. This is our first drill, second drill, third drill, fourth, fifth, and now we place the two implants. So, okay, so these are the sockets that we've been talking about. This is that piece of tooth that I've been talking about that wasn't removed. So we're gonna take that out now. Remove. This is the first drill, second, third. It's going sequence, and this is the implant itself. Okay. And now we're doing the same thing for the adjacent tooth. Okay, so this area, we're going to sew over the implant and let it settle for 3 months, and then after 3 months, we'll put the crowns on. And this is bone graft to help, like, so if you can see, the implants are smaller than the sockets. So there's this area here, to replace this with bone graft. And then we put dissolvable stitches, and then we'll get the crowns. Yeah, this is what the final X-ray looks like. Yeah, I don't have the pictures with the crowns on, but basically at this point, so, oral surgeons don't put the crowns on the teeth. At this point, we'll send them to the general dentist and they'll put the crowns on. I don't have those. But any questions about that?
No.
No? Okay. So I'm gonna go over jaw fractures, okay? So this was someone who was in a fight and came to our office. Okay, this is the inside of his mouth. So you can see he's occluding on this side, on his right side, but the left side is completely open. So you can see there's kind of a tear in his gum tissue here and here, okay? So this would suggest that the jaw is fractured in two places. Now we took an X-ray, you can kind of clearly see he has one here. And here. We'll go through a CT scan. This is the lower jaw now. Okay, so whenever someone has we can go over the basics of kind of what a CT scan is. Air is black, okay, and bone is white. So whenever you see these kind of black pockets of air, it means it's an open fracture. So air is coming in through his gum tissue into his soft tissue. Okay, now we're going sideways. You can kind of see the air here. And here's the fracture line. And here's the second fracture. Yeah, and this is a Reconstruction X-Ray. So here's our first fracture. And here's our second one. Okay. Okay, so before I go into the pictures of surgery, so the first things you want to do when someone has a broken jaw is you want to wire them shut. You let the teeth guide where the bones go. So once the patient is wired shut, it'll essentially line up the pieces of the bone together close enough. And then you open the area up and you put titanium plates, which is the same metals that we use for dental implants, to hold the fracture together. So that's what we're going to see, okay? So you can see the wires around his teeth. Okay. This is the first fracture. And now we put the metal plates on to hold it in place. Okay. And this is the fracture on the other side. You can see his teeth are wired shut. And then this is the metal plate here to hold it in place. So these are the wires that we put on. And these are the metal plates we put. Okay. This is called the angle of the jaw. On the angle, usually put one plate. It's called a chompy plate. It's very difficult to access the bottom of the jaw here. So when someone breaks their jaw in the corner, you have to decide and talk with the patient on whether you want to put one plate, which is not really the best. It's better to put a bigger plate on the bottom, but that would require you to make an incision outside their face and make a big scar. So a lot of people don't like that. So we try to do everything inside the mouth first with a smaller plate, just doing one. Whereas this area, which is just the side of the chin, it's much easier to access, and you can put the two plates that you need on. And you leave the patient wired shut for at least 2 weeks. Now we're doing another CT scan. Okay, you can see the metal plates are on. You can see the screws we put on are a little too big. Okay, so it's sticking a little through, but it's open. Look at like before and afters.
Oh, I appreciate you, my guy. Thank you.
Okay, cool. Questions about that one?
I have a question. Is there a limit to the amount of times where you can do this procedure? Just like fixing someone's jaw?
Is there a limit? I mean, ideally, you're going to get everything on the first try. These are things you do in a hospital with an anesthesiologist in a surgery center or surgery room. So you essentially have all the time in the world to get it right. But the better question is, what do you do when something goes wrong? Sometimes these metal plates can get infected and they don't work. So what you have to do is take the metal plate out, or let's say over here, and then you have to put another plate on, a bigger one, somewhere else along the same fracture. So that would be a limit on how many times you can do something.
Does putting a bigger plate limit the mobility of a patient's mouth?
Not really. Part of what you do when you put the metal plates on is bring the patient back to the office, and when you take the wires off, you have to teach them how to use their jaw again. You make them stretch open wide, and you make them kind of, because what happens is they can form scar tissue that won't let them open their jaw all the way. So you have to rehab them and do physical therapy. But that is more about the soft tissue, not really about the plates.
Thank you.
Anyone else? So I think I have one more. This is kind of a bigger one, okay? So this was a patient who was shot in the jaw, okay? So this is a gunshot case. So this is the bullet here. It's still there. And you can kind of see bone fragments here. And this is a breathing tube. Okay, so let's go back. So anytime someone's shot in the jaw, the tongues, the lips, the floor of the mouth can swell a lot, okay? And when it's swollen, it impinges the throat and the airway. So they have difficulty breathing. So we put a breathing tube in anyone who's kind of really shot in the jaw. So this is a breathing tube. I'm kind of showing it. This is still part of the breathing tube going down his throat, okay? And this is part of the entry area of the bullet. These pictures are probably kind of hard to tell, so I'm going to go through them fast. I'll do other tools. This is the inside of his mouth. Okay, here's his tongue. Here's one segment of the jaw. This is kind of fractured off. Here's another area here. So, do you guys know what impressions are? I think you worked in a dental office before. Basically, it's when you take a mold of someone's teeth. So we took a mold and we took it to the lab and take a saw and try to put the teeth back in the ideal areas and use that as a guide to bring the jaw back together. So basically over here, you can see that one tooth is back here and this other tooth is here. ideally these two teeth would be touching. So we cut here and place wax to reapproximate it. And we did the same thing in this area. So you can see, this tooth is not supposed to be all the way back here. It's supposed to be more over here. So we cut along the stone here. And we put wax, put in the ideal position. This is what we want his bite to look like at the end. So these are study models, right? We made a photocopy of his mouth and tried to break it apart and see where we can put it back together to get his bite back. These are the reconstructions, okay? So you can see the fracture here, so the fracture here, another one here, and here. It's kind of that free segment that I showed you in the photo. Here's the bullet still dislodged. Now inside. So again, remember the first thing we do is we wire the patient shut, okay? So these are called arch bar, Eric arch bars, the ones that go across. And then the first thing you do is you take a wire and wrap it from the Eric arch bar to the tooth. And then you take bigger wires to wire from one jaw to the next. And these are very strong. So the patients can't move after this. And they have to go on a liquid diet after. It is strenuous. They don't like it, but it's part of the way it is. I always just tell them, if you break your leg, you wear a cast, but if you break your mouth, you can't put a cast on if you wire. So this is what it looks like. And for him, since this was such a big fracture, we did have to make the incision outside the face, okay? So this is below his jawline. So this is the bottom of the jaw, okay? And you can kind of see the areas where it's fractured. This is more of the jaw being fractured here. And now we're starting to put on those titanium plates that we did before. So this is a fracture line here. And so now we're kind of piecing it back together with the titanium plates. So this kind of looks more like a stable jaw. And then for a fracture this big, then you have to put a bigger plate on. So I remember you were asking me, Tiffany, was it, about how many times can you do a surgery? And I said, sometimes when those mini plates get infected, you have to put a bigger plate on. This is the bigger plate that I was talking about. And since his jaw is so unstable, we had to go ahead and put the bigger plate on anyway. This is what those plates look like. It's kind of like putting the pieces of the puzzle back together. So this is the before and the after. And on the other side, and it's on the bottom. These are X-rays at the end. And so this is his breathing tube now. So to do the surgery, obviously we have to work in the mouth. So we took the breathing tube out and put it in his nose. So this is the mouth, and this area here is the nose. Okay, so you can see, and this is the breathing tube, this circle. So we put it in the nose now. I can just go over the basics of a CT scan if you want. So these are the eyes. This is your sinus. This is the nose. And here's our breathing tube. This is the upper jaw. Here's the lower jaw. Back. Okay, so this is the after. So here's our breathing tube going into his nose. Okay. These are the jaw wires, wiring his teeth shut here. These are our mini plates that we put on, our bigger plate. So you can kind of see the tube going from here into his nose and going down his throat at the bottom of the tube. And before and afters. This is them 6 weeks later, so obviously he has a big scar line at the bottom. And so I think you were asking me, or I was talking to someone about rehabbing the patient. So I'm going to teach him how to use his mouth again and stretch him out. The ideal opening you want for any patient is over 40 millimeters or 4 centimeters. So he's going above 40. So this is an ideal outcome. And this is his bite when the wires came off. So you can see his gums are kind of irritated. You can see the wires off, but this is a stable bite. He's biting on both sides. We're pretty happy about this. Okay, so this is exposed jawbone here on the same guy. So when a bullet enters someone, they carry a lot of heat, and it burns the surrounding tissue. So this is basically a thermal injury. The gum tissue is burned, and this is going to take a lot more time to heal. You'll see this a lot if you do oral surgery or any kind of jaw pathology. What you wait for is for the body to kind of push this dead bone out, and then you'll grow gum tissue over it. It's X-ray. That's all I had. Any questions about that?
Oh yeah, we actually have a question from Ashley in the chat about this last case. So what happens to like the small fragments of the jaw for the patient who got shot?
Small fragment. Okay, so we put the little plates on to stabilize those pieces of bone, and by stabilizing it, you will grow bone at the fracture lines, and it'll integrate and just be reincorporated in the jaw. Let's say we missed something and we accidentally didn't plate a piece of bone. What can happen is the body will spit it out. It will necrose, which means it kind of died. And it'll look like this. And you'll just remove it. And as long as the rest of the jaw is intact, the patient can still function. If it's a big piece of bone that you missed, and the patient spits that out, or the body pushes it out, that's a big problem. The patient can't function right.
Thank you, Dr. Eli, for this amazing presentation and for taking the time to explain each of the processes and like techniques to us. We really appreciate it. And with that said, we have a few questions in the chat, if that's all right.
Of course.
Okay, thank you. So the first question is, do you get paid while being in residency?
That's a good question. So you do get paid, but it's not like a real, it's not the same that you would get in private practice or like a dentist that's in private practice or anything. So it's about like $40,000 a year. So it's enough to cover living expenses, and that's really about it. Other programs will pay you more than others by like a difference of like $5,000 over the course of a year. And if you decide to do a 6-year program and go to medical school, you will have to pay for those years of medical school also. So if you go to a 6-year one, you're going to get paid when you're doing your surgery rotations, but not when you're doing medical school. If you're doing a program that doesn't have medical school, you got paid the whole way. But you're not getting paid like someone who graduated dental school, right? You're getting paid essentially what minimum wage is wherever you go.
Thank you, Dr. Eli. So another question that we had in the chat was, what can make you more competitive for residency program during dental school?
Okay. So, I hate to be dry, but really numbers, okay? You need to get a good score on that test. And I think they're allowing you to take it as many times as you want, and it's offered like twice a year. So you want to do really well on that test, number one. Number two is wherever you go to dental school, get in touch with the oral surgery professors that are at your dental school, and so they can write you a good letter of rec. It's mandatory to get letters of recommendation for a complete application. So if your oral surgery professors wherever you go are writing you good letters, it's a very good sign. And the third is externships. And that's when you do like a 1 week, 2 week internship at an oral surgery program. Those are the three most important things probably. So it's your score. Yeah, I probably should write letters of recommendation. So the NBME exam is what I'm referring to that you need a high score on. This, you need letters of recommendation and externships. These are the A, B, and C of an oral surgery applicant.
Thank you so much, Dr. Eli, for answering the question. Another question is, What's one piece of advice you would give to a future dentist that you wish someone would have given you?
It's a piece of advice. It's probably a good thing would be to keep balance. Okay, it's very dental school is not like college because when you're in college, you're going to see people with different majors. Your friends could have different majors, and you guys are taking different classes. But when you're in dental school, you're only around everyone doing the same thing as you. So it makes you very competitive and makes you kind of in this bubble. And it's good to get out of the bubble and just maintain your hobbies and activities you perform. Because if you spend a lot of time focused on your studies, you're gonna forget about those things. So it's good to maintain a balance.
Thank you, Dr. Eli. So the next question is, when a treatment doesn't go according to plan, how do you proceed with interacting with the patient?
Yeah, so that's going to happen no matter what you do. Okay, so that's going to happen whether you're a dentist, orthodontist, pediatrics. You will get complications, and I've noticed with patients, if you're just kind of honest and you're upfront about it, patients will be understanding if you're coming from the right place. And you, as a practitioner, should know where things can go wrong before you do anything, and let the patients know that beforehand. Like, if you're doing a filling, you can say, so when we're doing a filling, there's a chance that we do this filling and something goes wrong and you need a root canal. So you have to let the patient know that that's an option. And then there's a chance that when you do a root canal, the root canal won't work and the tooth needs to be removed. So the patients should have that planted in their seed before you do anything. You have to educate them. So if something were to go wrong, it doesn't come off as a surprise. And then when something does go wrong, you have to let them know, and you have to reinforce to them that you're their doctor and it's your job to make it right. So you're going to say, hey, we tried to do the filling didn't work, and now we need to do a root canal, and we're going to get it done. And that'll be the next thing we do. So communication is key. It's, and kind of, you just have to own up to it, I guess, if something does go wrong. So it takes some kind of maturity to do it, and that just kind of comes with the job. You'll develop it as you see more patients and kind of, once you make this your craft and you've done it so many times and you know what you're doing, you'll be able to communicate that with patients a lot more.
And thank you, Dr. Eli. So next, we were wondering, how did you prepare for cases during residency? And also, how did you practice procedures? Was it a similar process during dental school?
Okay, that's a good question. So you want to, it's not like dental school where you have a typodont. Do you guys know what typodonts are? It's like the fake patients made out of plastic. So in dental school, you get those and you practice on that. But in residency, there is no plastic patient. It's only on the real deal right away. So certain programs, when you're in your first year, they'll kind of attach you to someone older than you who's been in the program 1 or 2 years, and they kind of do some hand holding and show you how to do things. They'll do a procedure, you'll watch them, and then the next time you'll do it with them overlooking you, or your professor's overlooking you, you do it with them. And you have to do a lot of reading. All the surgeries I showed you have been documented, and there's textbooks on them and journal articles on them, and you need to really study those before going to an operating room. So between those two things, those are kind of the main ways to prepare. Yeah.
Thank you.
Sure.
Thank you, Dr. Eli. Our next question is, how did you deal with failure or disappointment during dental school and residency? And how did you pick yourself back up?
Yeah, Yeah, so failures don't feel good. Okay, it definitely ruins the weekend. And you know, you're gonna it's kind of, if you have a car, you're gonna get a parking ticket and you're gonna get a speeding ticket. It's part of just having a car. If you're gonna get into healthcare, you know, even if you do, I think most dentists and oral surgeons, if you're doing everything right 99% of the time, and something goes wrong that 1% of the time, I'm the type of person that I think about that 1% all the time. And you just have to know how to fix whatever went wrong. And you have to know how to communicate that with the patient. And, you know, as long as you aren't doing something that you're incapable of doing, and you're not doing something that's out of your reach, and something uneventful happens, or I'm sorry, something untoward happens during the procedure, you know, it's bound to happen. You just kind of have to accept it and just do your best to make it right. You know, but it will happen again, no matter what specialty you do. There will be cases that don't go right, but you can always make them right by doing, you know, by managing the complication and just kind of reading up on it. And you know, you want to keep going to CE courses and keep communication with other people in the profession and talk about your cases and keep pushing each other and keep kind of like educating each other on things that you've done wrong, what they've done wrong, and share information with each other. Okay?
Thank you, Dr. Eli, for that advice. The next question is, how does oral surgery differ from like the hospital setting compared to private practice?
Yeah, that's a good question. So private practice is mostly going to be wisdom teeth and implants. Okay. These are the two things on this when I wrote what is oral surgery. These are the two things you'll see in private practice. Okay. These other ones are more hospital based. Okay. The cases I showed you, except for that implant one, were done in the operating room. So when you finish your oral surgery residency, you become an oral surgeon, you associate with a hospital and you sign up to be a doctor at the hospital. So whenever they get cases like this, it's sent to you. Or whenever your friends who are dentists, you know, they'll call you and be like, hey, Josh, I see a patient. I think his jaw's fractured, or I think he has a tumor. And they send it to you. You take them to the hospital to do it. Whereas in the oral surgery office, like a private practice center, you know, you're not going to do these things in an operating room, but these other ones you will. So there are some oral surgeons who are very academic and very hospital-based, and they don't really do the implants and wisdom teeth, and they only do the reconstruction, repositioning, fracture, tumor surgeries. And on the other side of the spectrum are some that only do implants and wisdom teeth. You will have to know how to do all of this in residency, and then when you graduate, you decide your own way.
Thank you so
Thank
much
you,
for.
Dr. Eli.
Thank you, Dr. Eli. Another question is, how did you study and retain the information, and do you have any study advice?
I think if you're going into dental school and healthcare and everything, you just have to really stimulate your mind to like just be really good at memorizing and just processing a lot of information really quickly. You know, they do really push you in dental school and in residency to memorize a lot. So you have to like be focused and be willing to sacrifice time and kind of dedicate yourself to like whatever craft it is you pursue. Some people are really fast memorizers and some people are very slow memorizers. I was just kind of in the middle. And I just really, when I had to study, really just pushed myself to do as much as possible. So, I mean, that's how I did it, but everyone's different. So, if you're really good at memorizing, then it's gonna be a lot easier for you. If you're really bad at it, you're gonna have to sacrifice more time, but you just kind of have to figure out what works for you along the way. So.
All right, thank you, Dr. Eli, for your question, for your answer. Another question is, what factors made you decide to attend UCLA for dental school and Highline Hospital for residency?
Oh, okay. So I'm from Los Angeles, and UCLA had a very good reputation, and also, other schools in the area had a higher tuition, so student loans also matter. So putting those things together, UCLA was the right fit for me. And then when I was graduating dental school, again, I remember I mentioned there's 4-year programs and 6-year programs. I wanted to go to a 4-year one, and Highline, Oakland, in my opinion, was a very good 4-year program in California, and I kind of wanted to stay on the West Coast. So I applied there, and I didn't mention this, but when you apply to residencies, it's not like applying to college or dental school where you get multiple acceptances and you get to pick where you go. It's a match system. So you interview at all the programs that want to interview you, and then you rank them all on a scale of 1 to 10, which ones you like the best, which ones you like the least. And then one day everyone just gets an email saying where they're going. Okay, so I ranked Highland pretty high. I was happy that I got assigned there. It was a good match for me. So you don't really have a choice as much with residency as you do with dental schools, because you only get into one place, right? So again, you want to do the externships and visit all the programs. This is probably what's going, and pick the one that you like best. Okay, some programs, they're very different. Some places make you do a lot of cancer cases. Some places do very little cancer cases. Some places do a lot of trauma, and you have to see which one you like the best and kind of push for it.
Thank you, Dr. Eli. So I think our last question here is, what would you say is the most challenging aspect of dental school and residency in your opinion?
The most challenging thing, again, it is probably just time management, I think. Again, when you're in college, everyone you know is in college. All your friends are in college. But when you're in grad school and residency, it's very possible that your friends and your group that you grew up with kind of just starting their careers and starting families. So you have to be able, if you have a partner that's willing to go through it with you, it's great. It's probably the best you can have in your advantage. You don't have those things, you're going to be sacrificing a lot of time and spending a lot of time on your own. And even if you have a family, like some people have kids in residency and dental school, you're going to be spending a lot of time away from them because, it's very demanding to do these things. So, there's time away from family, time away from your kids, time away from community, whatever. That is a little bit more challenging than academics for some people.
Okay.
Well, thank you, Dr. Eli. Unfortunately, that's all the time that we have today for questions. So I just wanted to say thank you again for taking the time to be here with us and for sharing your cases. And for everyone who joined our session today, just before we end, the link for the quiz will be posted in our group meet. And yeah, thank you again, Dr. Eli, for being here with us.